Hello everyone. Let's continue our discussion on chemotherapy again. In the previous lectures we have discussed about cell wall synthesis inhibitors which are penicillin and cephalosporin. In this session we are going to discuss other drugs which are also inhibiting the cell wall synthesis and use as antibacterial. Just to revise the classification of the chemotherapeutic agents which are acting on cell wall, they are divided into two categories. One is beta-lactam antibiotic and others. In beta-lactam antibiotics, we have penicillin, which include penicillin G, penicillin V, amoxicillin, ampicillin, dicloxacillin, and many more. In cephalosporins, we have first generation, second generation, third generation, and fourth generation cephalosporins. And these two drugs has been covered in previous sessions. In today's class, we are going to discuss about Monobactam, Carbapenem, and other drugs which are also acting on the cell wall synthesis. Just revising the structure of cell wall. Bacterial cell wall is consisting of two layers. One is inner cytoplasmic membrane and other is outer membrane. Just beneath the outer membrane there is a presence of peptidoglycan layer, and penicillin and cephalosporins are acting here on this peptidoglycan layer to inhibit the cell wall synthesis. Into the inner cytoplasmic membrane there is a presence of penicillin binding protein, and into the outer membrane there is a presence of porine channels which allow the entry of molecules inside the bacterial cell. The bacteria which releases the beta-lactamase enzyme, it is initially released into the periplasmic space. Periplasmic space is a space between the inner and outer membrane. There is a difference between the structure of this gram positive and gram negative bacteria. In gram positive bacteria, this peptidoglycan layer is very thick and strong, and in gram negative bacteria, this peptidoglycan layer is very thin. That is the only difference between the two types of bacilli. Now we come to the mechanism of action of the beta-lactam antibiotics. As discussed earlier, beta-lactam antibiotics like penicillin and cephalosporin, they inhibit the reaction transpeptidase so that there is elongation of the polypeptide chain cannot take place. Ultimately, cell wall deficient form of the bacteria is generated, and that bacteria cannot survive into the external atmosphere, and bactericidal effect is produced. The same mechanism is followed by the Monobactam and the Aztreonam. Now we come to the new class, that is Aztreonam. It is also called as Monobactam because here you can see into the chemical structure of the Aztreonam that it contains only a single penicillin ring. That is why it is called as monocyclic beta-lactam, because it contains only single ring. It is highly effective against beta-lactamase producing organisms like gram-negative bacilli, which include Enterobacteriaceae, Klebsiella, Pseudomonas, Serratia, and H. influenzae. It is also active against gram-negative cocci, that is Neisseria meningitidis and Neisseria gonorrhoeae. Gram-positive bacteria and anaerobic organisms are now resistant with the Aztreonam. Aztreonam can be administered intramuscularly or intravenously. Because of the poor oral absorption, the drug is not available for oral formulation. It is excreted unchanged into the urine, so in kidney disease patient, dose adjustment is required for the Aztreonam. But the most important parameter or the characteristic of the Aztreonam which makes the drug very important in therapeutics is that it does not share cross hypersensitivity with the beta-lactam group of antibiotic. So it is the only beta-lactam group of drug which can be given to the penicillin allergic patients also. Adverse drug reactions of Aztreonam are nausea, vomiting, diarrhea, urticaria, rash, increase in the transaminases leading to hepatitis, and sometimes blood disorders like thrombocytopenia and neutropenia has been reported. It is used as a reserved drug. It can be used as an alternative to aminoglycosides in septicemia or in complicated UTI because of its activity against gram-negative bacteria only. One important and other use of the Aztreonam is that It is also available as inhalational formulation, which is used for the treatment of cystic fibrosis, which is a disorder of the lung where the fibrosis into the lung starts, and Aztreonam by inhalational route can be useful for this condition also. Next group of drug in this session is carbapenems. Carbapenems include imipenem, meropenem and itrapenem. Here is the chemical structure. All the carbapenems are considered as beta-lactamase resistant. That is why they have very broad spectrum of activity. They are active against gram-negative and gram-positive both aerobic as well as anaerobic microorganism. Example Streptococci, Enterococci, Enterobacteriaceae, Pseudomonas, Acinetobacter and anaerobes like Bacillus fragilis. They are not effective against E. faecium, MRSA and Clostridium difficile. One of the important fact regarding imipenem is that the drug is having very different or characteristic pharmacokinetic properties. Imipenem is a prototype of carbapenem group of drug. It cannot be given orally because of the poor oral absorption. That is why it is always given by intravenous route. If we see the distribution, it is widely distributed into the body. It penetrates all body tissue and fluids including CSF. The drug is metabolized by the kidney. It is rapidly hydrolyzed by the enzyme dihydropeptidase, which is located into the brush border of the proximal tubule of the kidney. So if the drug or its metabolite they are directly excreted through the kidney, they become very toxic and it produces nephrotoxicity as a side effect. That is why imipenem is always given in combination with celastin. What is celastin? Celastin is a molecule which inhibits the renal dihydropeptidase enzyme. It does not have antibacterial property of its own. It just inhibits the renal dihydropeptidase enzyme, so reduce the metabolism of the imipenem and reduce production of the metabolites and ultimately help in prevention of nephrotoxicity, which can be a very serious side effect of imipenem. The drug is also excreted through the kidney, so dose reduction is required by the into the patients of kidney failure. Here is the explanation why imipenem is always given in combination with the celastin. Into the diagrammatic way, here you can see that imipenem is reaching the renal tubular cell and it is get excreted by the organic anion transporters. The metabolites of the imipenem are also getting concentrated into the kidney and produces nephrotoxicity as a very serious side effect. Celastin is a molecule which inhibits the dihydropeptidase enzyme which is located into the kidney. So the production of the imipenem metabolites is inhibited, so the nephrotoxicity can be prevented. So imipenem is a drug which is never given alone. It is always given in combination with celastin. Dose of imipenem is around 0.25 to 0.5 grams intravenously every 6 hourly. Plasma half-life is around 1 to 3 hours. Concurrent use of bacteriostatic drugs like chloramphenicol will antagonize the effect of imipenem, and concurrent use of aminoglycoside will be synergistic for the imipenem. Only disadvantage is that drug is very costly, so it should be used only it is absolutely required. Therapeutic uses, it is the reserved drug for resistant infection only. The infections which are caused by organism resistant to other drugs like urinary tract infection, lower respiratory tract infection, nosocomial pneumonia, intra-abdominal and pelvic infections, septicemia, skin and soft tissue infections, bone and joint infections, they all can be treated by imipenem celastin. But we should first try all other drugs, and if the organism is resistant to other commonly used drug, then we should go with the imipenem. It can also be used for the treatment of mixed infections which are caused by cephalosporin resistant nosocomial infections such as Citrobacter and Enterobacter. So imipenem is a carbapenem which is a bactericidal drug and inhibits the cell wall synthesis. Always given in combination with celastin, which is a renal dihydropeptidase inhibitor. It does not have its antibacterial activity of its own but limits the renal metabolism of the imipenem and thus it prevents the nephrotoxicity. Recently, a new molecule has came in market, that is relebactam, which is also given as in combination with imipenem. It is a new beta-lactamase inhibitor. It inhibits the class A carbapenems and class C cephalosporinases. So there is no intrinsic antibacterial activity with the relebactam, but it protects the imipenem from the degradation by the other beta-lactamases and other serous enzymes which can destroy the imipenem. So imipenem celastin combination can be considered as a broad spectrum agent with both gram positive and negative coverage. It is generally reserved for the Pseudomonas and ESBL producing Enterobacteriaceae. Increased resistance has been reported with the imipenem due to production of carbapenemases such as Klebsiella pneumoniae carbapenemase and class C cephalosporinases, which is transferred example is AMPC. While combination of imipenem plus celastin, combination of imipenem with relebactam, it restores the imipenem activity in the phase of resistant Pseudomonas and Enterobacteriaceae, and it is having strong inhibitory carbapenemase activity. That is why this new combination is nowadays highly used in place of imipenem celastin. Adverse drug reactions of imipenem is that it increases the seizure risk and it causes Clostridium difficile associated diarrhea, which is a serious side effect, may require discontinuation of a drug. Other adverse drug reactions include diarrhea, nausea, headache, vomiting, increased liver enzyme, phlebitis or the reaction at the infusion site, pyrexia and hypertension. After imipenem, there are certain new molecule into the same class has been discovered. They all are having the advantage that they are not metabolized by the renal dihydropeptidase enzyme. So they can be given alone. There is no need of combination of celastin with them. One such agent is meropenem. It is not hydrolyzed by the renal dihydropeptidase enzyme. It is effective against imipenem resistant Pseudomonas also. It crosses very well the blood-brain barrier, so it is one of the very useful drug for the treatment of meningitis. Other uses are similar to imipenem. Other drugs are itrapenem. Itrapenem is having longest half-life and can be given once a day, while ferropenem is orally active substitute of imipenem. So if we combine all adverse drug reaction of the whole carbapenem group, they produces GI upset like nausea, vomiting, diarrhea, abdominal pain, allergic reaction which may range from skin rashes to severe anaphylactoid reactions, reaction at the infusion site which include pain, inflammation of the vein, etc. Seizure activity is very highly seen though into those who are having other CNS disorder previously or those who are having renal insufficiency. Seizures are less with the meropenem and itrapenem, and hypersensitivity reaction may occur because the cross sensitivity with the penicillin exists. So if patient is allergic to penicillin, you cannot give carbapenem class of drug. Now we move to the miscellaneous antibiotics or other antibiotics which are chemically not beta-lactam in nature but still they act on the cell wall and inhibit the bacterial growth. One such drug is vancomycin. By class it is a glycopeptide antibiotic. It is bactericidal drug and it is obtained from the Streptococcus orientalis. If we see the spectrum of this drug, it is effective against gram-positive organisms only. It is active against aerobic as well as anaerobic gram-positive organisms like Streptococci, Staphylococci including MRSA, Enterococci, Peptostreptococci, C. diphtheria, Listeria, C. tetani, etc. Mechanism of action. It is inhibiting the cell wall synthesis, as we all know. It acts by complexing with the D-alanine portion of the terminal end of the peptidoglycan pentapeptide. So ultimately, polymerization of the glycopeptide layer does not take place, and cell wall deficient form of the bacteria is generated and bactericidal action is produced. Here you can see the mechanism of action of the glycopeptide into the diagrammatic presentation. It combines with the D-alanine end of the polypeptide chain, and by combining here it does not allow further growth of the peptide chain, so the bacterial cell wall cannot be synthesized properly and cell wall deficient form is there, leading to bactericidal effect. Vancomycin is a drug which is also having poor oral bioavailability, so it is always preferred by IV route, but rarely it can be used orally also, where the action is required locally into the GIT. 90% of the unchanged drug is excreted through the kidney. So if we have to if we have to list the uses of vancomycin, it is drug of choice for MRSA. It can be useful for treatment of sepsis or endocarditis which is caused by MRSA. In combination with gentamicin, it can be used as an alternative for enterococcal endocarditis in a patient with serious penicillin allergy. In combination with cefotaxime, ceftriaxone or rifampicin, it can be used for the life-threatening meningitis treatment also. Oral vancomycin is used to treat antibiotic-associated enterocolitis caused by Clostridium difficile, also called as pseudomembranous colitis, where patient suffers from severe diarrhea not responding to any other drug. The diarrhea is so severe that it may lead to life-threatening complication and require discontinuation of the most of the drugs which causing PMC. Oral vancomycin is drug of choice for this condition, where vancomycin's action is required locally into the GIT. That's why we give vancomycin orally, because it is not absorbed, it remains into the GIT and help into the treatment of pseudomembranous colitis. Severe staphylococcal infection into penicillin allergic patients, it can also be used, but make sure that you should not use vancomycin into penicillin sensitive patients. If patient is non-allergic to penicillin, it is best to use beta-lactam antibiotics first, then vancomycin, because vancomycin is not very fast in action. So as far as possible, if patient is non-allergic to penicillin, you should go for the penicillin or beta-lactam group of antibiotic first. And if patient is allergic to penicillin or beta-lactam group of antibiotic, then you should choose vancomycin. Adverse drug reactions of vancomycin are listed here. Most important and typical side effect of vancomycin is red man syndrome. It is also called as red neck syndrome, which occurs because of the huge histamine release. When patient take his vancomycin intravenously, it causes release of histamine into the blood vessels of the face and neck, which makes the face and neck region hyperemic or red in color. That's why the syndrome is called as red man syndrome. Other side effects are ototoxicity, nephrotoxicity, skin rash and allergic reactions. It can cause reversible neutropenia, chills, fever, etc. So to avoid this side effect, one should make a habit to monitor serum trough concentration of vancomycin, because it is always associated with the adverse drug reaction. Dose adjustment is always required into the renal impairment patient. But because of its large molecular size, it cannot enter through the porine channel, so it is not effective for the management of gram-negative organism. So for vancomycin, it is only effective for gram-positive bacteria. It is not meant for gram-negative organisms. Here is the just diagrammatic presentation of the red men syndrome. Redman syndrome is nothing but the patient's face, neck, and whole upper body will be converted into rashes, red colored because of the rashes, erythema, and pruritic manifestations, which are shown here into this diagram. After vancomycin, they came in market where telavancin, dalbavancin, and oritabenzin. They are second generation glycopeptide antibiotic, and therapeutic uses are almost similar to vancomycin. Next group is teicoplanin, which is similar to vancomycin, but it has having more activity against enterococci, and it is used for the prophylaxis against endocarditis and peritonitis, and it can also be useful for the treatment of pseudomembranous colitis. Advantage of teicoplanin is that it does not cause red neck syndrome, but it may cause bronchospasm as a mild reaction. It is useful for the patients those who are not tolerating vancomycin. Next class of antibiotic is daptomycin. By class, it is cyclic lipopeptide group of drug. If we see the mechanism of action, in presence of calcium, it binds with the bacterial cell membrane and disrupt it. It causes rapid depolarization of the membrane, so ultimately cell death occur and bacteria cannot survive and leading to bactericidal action. Antibacterial spectrum of daptomycin is similar to vancomycin, which means it is effective for gram-positive organisms only. Here is the mechanism of action of daptomycin, that it disrupts the cell membrane, causes depolarization of the membrane, and ultimately cell membrane is lysed and bactericidal action can be produced. Therapeutic uses of daptomycin are listed here. They are similar to vancomycin. It can be useful for the treatment of complicated infections of skin and soft tissue. It can be useful for staphylococcal bacteremia and right-sided endocarditis. It is not preferred for the pneumonia because interaction with the surfactant present into the lung will make the drug inactive. So some important point to remember about daptomycin is that it produces concentration dependent killing. It is also having post antibiotic effect and it is available for IV use only. Here highlighting fact is that therapeutic uses are all similar to vancomycin except daptomycin cannot be useful for the treatment of pneumonia because surfactant present into the lung will make the drug ineffective. So daptomycin should never be used for the treatment of pneumonia. Next drug is Bacitracin. This is the drug which does not contain beta-lactam ring. It is used as topical antibiotic. It is cyclic peptide mixture first obtained from the Tracy strain of Bacillus subtilis. If we see the mechanism of action, it inhibits the cell wall formation by interfering with the dephosphorylation of the lipid carrier that transfers the peptidoglycan subunit to the growing cell wall. The drug is highly nephrotoxic, that is why it is used topically. The nephrotoxicity is so high that it limits the parenteral administration or even oral administration. You can only use bacitracin as a topical formulation of cream, ointment or powder. It is indicated for suppression of the mixed bacterial flora into the surface lesion of the skin, into the wound or into the mucous membrane. Here is the mechanism of action of bacitracin. The peptidoglycan layers are synthesized and this side chain will be transferred from the one side to the other with the help of lipid carrier. This lipid carrier will cause recycling of the peptidoglycan chain and this lipid carrier is disrupted by the bacitracin, so the cell wall cannot be synthesized further and the growth halts at this level. That is why bactericidal action is produced. But because the drug is very nephrotoxic, you have to limit the use to the topical infections like skin and soft tissue infection. in the form of cream or ointment only. Next drug is Fosfomycin. Fosfomycin is also bactericidal agent. Mechanism of action is that it inhibits the cytoplasmic enzyme enol pyruvate transferase and blocking the addition of phosphoenol pyruvate to UDP N-acetylmuramic acid. Thus, it inhibits very first step of cell wall synthesis inhibitor. It is active against both gram-positive and gram-negative organism. It is approved for the use as a single dose of 3 gram into the treatment of uncomplicated lower urinary tract infection into the woman. Also, it is the drug which is safe during pregnancy. Here the mechanism of action of fosfomycin is shown. You can see here that it inhibits the very first step of synthesis of the peptides for the glycopeptide chain generation. Another drug is cycloserin. Cycloserin is produced by Streptomyces orchidaceus. Mechanism of action, it also inhibits the cell wall. It is a structural analog of the D-alanine and inhibit the incorporation of the D-alanine into peptidoglycan pentapeptide by inhibiting alanine racemase enzyme. So cell wall synthesis cannot take place further and bactericidal action is produced. It is used almost exclusively to treat tuberculosis nowadays as a second line drug for tuberculosis. Side effects associated with the cycloserin are central nervous system related toxicity, which include headache, tremors, acute psychosis and convulsion, which requires constant monitoring of the patient. Here you can see the mechanism of action of D-cycloserin, that it is structurally similar to alanine. So by inhibiting the racemase enzyme, the D-cycloserin will inhibit the further synthesis of the glycopeptide chain and the cell wall cannot be synthesized properly. So this is all about all the miscellaneous agents which can be useful for the treatment of microbial infections where we require agents which affect the cell wall synthesis inhibition. Thank you all. If you have any questions or query, you can ask. Thank you so much.